And next is our chief instructor, Dr. Rajendra Prasad. He'll be talking on T-Soft, the new technique to manage sticky, soft, and glued cataract.
Good evening, and thank you, Dr. Bharti sir, for the nice words and for being here with all of us in this beautiful evening. And this subject which I am going to talk about is soft cataracts. And you know that these soft cataracts, we all have started coming across more and more in our surgical practice. The reason you all know that it's basically the patient's requirement, and we have already finished this hard cataract now. That is the reason, like, we have to be now into the soft cataract, and we have to learn how to manage these soft cataracts. Okay. So the biggest problem we come across while dealing with this soft cataract is like it's like a glued kind of material and sticky material. So what you have to, what we come across, the problem is like you can't hold the nucleus, and you are not able to rotate it properly. And while splitting, like, you are not able to crack because it's very soft. You can't crack them. So you cannot separate or split the nucleus into segments. And if you are not able to segment the nucleus, then you tend to use the second instrument more and more, and trying to bring that soft material towards the phaco probe. Now this becomes very risky because many times, because if you are holding this like this, so going very close to the posterior capsule, and since the material is very soft, there are always the chances of this phaco probe hitting the posterior capsule. This is what happens. One of the complications we may come across with this soft cataract. And if you hit the posterior capsule, because this is another soft cataract, as you can see, because you try to hold the cataractous complex, because you don't have very hard nucleus. It's just the cataract cortex, epinucleus, and nucleus all combined. It forms a complex, and it hits the posterior capsule, and you get into the problem, the posterior capsular rupture. As you can see here, now there is a complete opening of the PC. So what you need to do with these soft cataract is, the first important thing with the soft cataract is your hydro procedure in the capsular axis has to be perfect. So do a good capsular axis. Never do a capsular axis thinking that it's a soft cataract, you should not land up with these small axis. Try to do a little larger axis of around 5.5 to 6 millimeter, because the larger the axis, you'll be much better, you'll be managing these soft cataract. And creating a rhexis again in a soft cataract is always a challenge. So your vector forces has to be accurate so that you don't get into the extension of the capsular axis margin. So make a capsular axis of around 5 to 5.5 millimeter, like I'm doing here in this video. And once you complete the rhexis, then the second step which comes up is very important, the hydro procedure. As you can see, I'm using a hydro cannula, and see the wave which is going underneath. So this is what is required, because you have to do a complete cortical cleaving hydrodissection. If you do not do the cortical cleaving hydrodissection, because generally, as I said, the cortical material is stuck to the capsular bag. So while doing the aspiration, while doing the manipulation in the center, you have to use more of second instrument, and then the complications may arise. And look at the type of the needle you have to use for the hydrodissection. It should be a flat needle, because there are fluid wave. If you want to create a complete cortical cleaving hydrodissection, your fluid has to go, it has to spread when you inject. Don't just leave the needle at the capsular axis margin. Go little inside, at least 2 millimeter inside, towards the equator. Don't inject at the margin, what we do in the hard cataract, but in the soft cataract, don't inject at the margin. Go little inside and inject fluid at the equator. If you do that, then you get a good wave of capsular axis, and you get a complete capsular axis in these cases. So once you do the complete capsular axis, you have a lot of techniques available now. Several techniques. We are all practicing many of these techniques. But the important point which I'll show you here is, because if you come across a very soft cataract, like in a pediatric cataract or very early age cataract, these are absolutely soft cataract. So in a pediatric age group cataract, as you can see here, this video, because I'm doing a side port, it's complete, always stain the capsule. It's very important because otherwise you lose the capsular axis margin. Stain and start from the center. As you can see, you have to stretch it more. So if you try to stretch it more, then there are always chances of extension. So keep your central forces towards the center and go very slowly. And now you can see I've completed the axis. Now material is not much. It's just the fluffy material and a little bit of hardened material at the center, but you can use just the coaxial aspiration or the bimanual aspiration technique only. You can aspirate the whole material out of the capsular bag. Now once you complete this, and if you are dealing with a pediatric cataract of less than 5 years of age, always do a PCC. So what I'm doing here, I'm trying to do a PCC again. So PCC again doing is very important because, and it's must in these cases, otherwise you'll end up with the capsular opacity, and then YAG laser doing in these small kids is very difficult. So do a good PCC as you can see here, and once you do the PCC, if the child is less than 3.5 years old, must do an anterior vitrectomy, otherwise you'll end up with the vitreous membrane formation. That is another problem. So inject the IOL into the bag. So always make sure that your IOL is going into the bag, not on the anterior capsule or in the sulcus. So this is how you can complete the surgery in these pediatric cases. Always put a suture. So another important point, because the sclera is very elastic, so opening the healing or sealing is not possible. So always put a stitch. Now if you get a soft cataract which has a bit of firmness in the nucleus, then the best way to do is, this is called as a visco-flap technique. Visco-flap technique means you are injecting viscoelastic to completely dislodge the whole cataractous material out of the capsular bag. This is very simple technique. Just go underneath the capsular bag and inject a good amount of the viscoelastic. Now once the whole complex is out of the bag, you don't have to struggle. You can very simply go inside with the phaco probe and start aspirating the whole material. This is how you can complete the whole surgery with a single shot and aspiration of the whole complex material. But many times you come across these acquired soft cataract which are a little more sticky and more glued kind of thing. So in these cases, the best way to, after completion of the axis and all and hydrodissection, do a stop and chop technique. But important point in doing the stop and chop technique in these cases is like your phaco probe, look at the direction of the phaco probe. It has to be parallel of the surface of the nucleus. Don't keep it vertical like we do in the hard cataract. In hard cataract, we make a trench vertically, like you go deeper. Here you don't have to go deeper. You can just split the nucleus into two, rotate it. Now you have a two heminuclei, and then taking out these heminuclei becomes very easy, because if you are able to completely separate the two heminuclei, as you can see here, then the heminuclei will automatically come on the phaco probe and you can completely start aspiration. This is how you complete the first heminuclei, and rotate it and take out the second heminuclei, and you can complete the surgery. And it's so simple. But you have to split the nucleus. So splitting is very, very important in these cases. If you are able to split, then you can come out. And then comes this soft senile cataract. These are the little more difficult soft cataract, because you have a little more firmness and more glueness. So in these cases, a simple technique which I called as a T-soft. T-soft means you are using a splitter. It's not a chopper, you are splitting the nucleus. See, as you can see here, because just hold the nucleus with very low vacuum and without any phaco power, hold it and split it. So if you are able to split, because the splitting of these soft cataract is very important, because if you are able to split, then the whole process becomes very easy. Because you are not able to split, then you start making, because you get into the problem of Swiss cheesing and Swiss wire cutting of the nucleus, because the sharp choppers won't work. So you split the nucleus into multiple fragments or two fragments, then you can completely complete the surgical procedure and finish off the aspiration or emulsification of these softer material. And as you can see here, because I'm doing the completion of the aspiration, and this is how you complete. And once you complete, then you can go ahead with the intraocular lens implantation. Another important point is like polishing is very important. In these soft cataract, because there are immature cells which is lying in the fornices and on the posterior capsule. So you do a good polishing of the capsular bag, like anterior as well as the posterior capsule. and then inject the IOL into the bag, and you complete the surgery. Then comes up the little complex soft cataract. This is the soft posterior polar cataract, as you can see here, because you have a good posterior polar cataract which is seen after doing the minimal hydrodissection, which I call as a peripheral hydrodissection, not the central one. You split the nucleus into two. Again, I'm trying to split, and without rotating, just bring these pieces on the phaco probe, and you inject viscoelastic, a good amount of the viscoelastic before you take out the phaco probe. And then with the bimanual technique, you can do a very simple aspiration of the cortical and the epinuclear material, and without tackling. But in this particular case, as you can see now, we have a PCR, a big PCR, which is a radial PCR, which has happened. This was pre-existing PCR already there. And now if you have a PCR, then don't worry, like you have to just because generally because in these cases you don't get the vitreous prolapse, because vitreous piece is always intact because the pre-existing PCRs. And I'm going ahead with the single piece IL implantation. The important point is that leading haptic, if you are able to put in the bag, is the best, but otherwise you can keep it on the anterior capsule. And then once you keep it on the anterior capsule, and with one by one, a nudging technique, which is called as the haptic nudging technique into the capsular bag, inject good amount of the viscoelastic, and with the dialer, then you can just hold one of the haptic and put it into the bag. Now this is how the one of the haptic has gone into the bag, and similarly the second haptic, you can just slightly dial or nudge it into the bag. So this is how you complete this, and the remaining some amount of the cortical material, which you can completely aspirate later on. This is how you complete the surgery. And as you can see, there is no vitreous, so you complete the surgery. So to conclude, the soft cataracts, the important point in soft cataract is because you have to use very low parameter of the phaco. Always split the nucleus into two segments so that better aspiration of the nuclear material, and use the technique which is more comfortable with you. Thank you. Thank you very much.
Excellent talk, Dr. Rajendra Prasad. It gives us an idea as to how to manage these soft cataracts and divide and chop them.